afternoon to everyone. I welcome Dr. Deepak Govil, Vice Chairman, Critical Care Department at Medanta, the Medicity at Gurugram. I welcome you all for the Meet the Expert session on toxicity of polymyxins, prevention and management. So, sir, the first question regarding the understanding of toxicity of polymyxins. What are the most common and clinically significant toxicities associated with polymyxins, particularly colistin and polymyxin B in critically ill patients?
So mainly there are two types of toxicity. One is the nephrotoxicity and another is the neurotoxicity. These are associated more predominantly with the colistin and little less with the polymyxin
Okay,
B.
sir. Okay. And regarding the risk factors, what patient and treatment related factors increase the risk of nephrotoxicity and neurotoxicity with polymyxins, and how can these risk factors be mitigated?
If we talk about risk factors, there are two types of broadly we can divide them. One patient related risk factors and another is disease related risk factors. So patient related risk factors are any comorbidity like diabetes, like patient who are prone for any type of any nephropathies, be it a hypertensive nephropathy, be it a diabetic nephropathy, those are the subgroup. Elderly age group, they are more vulnerable, and those patients who are alcoholic, different type of comorbidity, they also play a role. And then certain diseases that can cause, like in sepsis, majority of the patient develop AKI. In septic shock, almost 1/3 of the patient they develop AKI or they are prone to develop AKI. And this such setting, if we are giving any drug which can increase the risk, then the chances of developing AKI are there. Then, of course, in such patients, multiple drugs are being given, and because of those drugs, NSAID and other nephrotoxic drug, they also can cause the increase in the nephrotoxicity by these drugs.
Okay, sir. So next question regarding the dosing strategies of polymyxins. How can optimized dosing strategies, including PK/PD considerations, help reduce toxicity with maintaining efficacy while maintaining the efficacy?
So dosing schedule we have to give. They are the basically concentration based effect. So if we give a loading dose, our consideration of loading dose should be independent of any pre-existing kidney disease, unless patient is having chronic kidney disease. So if because of sepsis patient is having AKI, we should not consider that as a deterrent to give the loading dose. So loading dose should be given, and after that maintenance dose can be adjusted as per the kidney functions.
Okay, sir. So next question regarding a very interesting topic about combination therapy versus monotherapy. So does using polymyxin in combination with other antibiotics reduce the risk of toxicity, or does it merely improve the efficacy of polymyxin Bs? And what are the latest insights on this approach?
So when we reinvented polymyxins or colistin around 15-20 years back, they were in fashion earlier, then they went off the scenario. But as these gram negatives, they developed more resistance, then they came into again in the picture. The existing guidelines, Western guidelines, they all support that colistin and polymyxin should not be used as a monotherapy, they should be used as a combination therapy. But what we see in India or saw in India in last 10 years, most of the time the susceptibility is only with the colistin. And at that point of time, there is always a debate whether to give with combination or to give as a monotherapy. Because if I am combining it with a Penams or any other drug which is showing resistance, then probably there are two school of thought. One says you are unnecessarily increasing the toxicity by adding another drug, and you are increasing the cost as well by increasing another drug. Another school of thought says, why don't you use combination therapy? There could be possibility of a synergistic effect. But leave aside those group where nothing is sensitive except colistin. The main question arises where colistin and other drug are also sensitive. At that point of time, if we start using as a combination therapy, probably we can reduce the doses, we can reduce the duration of therapy, and we can reduce the toxicity.
So what is your personal preference for combination therapy or monotherapy or from patient to patient?
It depends on patient to patient. As I've already said, if patient is sensitive to penems, I'll not go for colistin.
Okay.
I'll go with penems. If my patient is resistant to penems, then I'll have to think what to add. Many times you find that this tigecycline and colistin, they are the only two sensitive bugs against against Acinetobacter. Then what are the options? Then we think where this PKPD of the drug which I am combining with colistin, because if the target site where I want to have the action, that drug is not penetrating, there is no fun giving combination therapy. So combination therapy is always being adjusted or weighted as the need based to individual patient, whether this patient is going to benefit, or many times we are just adding the combination therapy of heck of adding and increasing the cost to patient.
Okay. So my next question on renal function monitoring of the patients. What are the best practices for monitoring renal functions in patients receiving polymyxins, and when should dose adjustment or discontinuation be considered?
If there are 2-3 subgroup of the patient, mainly those patients who are come up with a say this pyelonephritis and urinary tract infection, their their creatinine is already high. Once the therapy takes place and the bacterial load decreases, and then gradually their creatinine improves. At that point of time, we have to give the high dose as a loading dose as a first dose. Then we can tailor made the therapy according to their creatinine level. And as the creatinine improves, we calculate creatinine clearance of last 24 hours, and we can tailor made the therapy accordingly. Although there in other, like in a bacteremia or in a septicemia, bloodborne infection, or in the chest, the concept is the same. We give a loading dose, then maintenance dose, and gradually we tailor made according to the creatinine clearance. Now comes up the few new biomarkers are there, like NGAL. Many people feel that we can monitor the NGAL level, and if it is going up, then we can tailor made or we can avoid little early. But again, it's a debatable cost of NGAL. I'm not sure why NGAL type of biomarkers have not come up to the day-to-day practice in our practice. I'm sure that in India, very few centers are practicing it as a, except in a study purpose, they are practicing it as a day-to-day basis. So again, the creatinine and creatinine clearance and the urine output, they remain the gold standard in our part of the world to tailor made.
Are there any recent advances in adjunctive therapies or renoprotective strategies that can help mitigate polymyxin-induced nephrotoxicity?
There could be certain combinations which can reduce the stress to the tubules and decrease the toxicity, but I am not very sure how they are working, and we need to have a proper study and a trial to prove their efficacy if
Okay.
they are
Okay.
working.
And my last question regarding future directions of using polymyxin B. With the rising concerns with polymyxin toxicity, are there promising alternatives or next generation polymyxins like velimyxin in development that could replace or supplement their use in critical care?
Yeah, of course, if the drug newer molecule is coming which are not having that much of amount of toxicity, they have got good potential. But we have to see the PKPD, which is what is the active drug in that molecule, what is the site of action, how they are being excreted, how they are being metabolized, and what is their efficacy against the basic pathogen for which we are using it. So that all things has to be seen, and once they are established, then of course they have got good potential.
Sir, and how has your experience with velimyxin been overall?
Yeah, it's overall it's a good experience, but again I have said the experience is not that great. For polymyxins we are using for 15-20 years. Valimyxin in our institution we have started using recently.
Okay.
Of course we see lesser number of nephrotoxicity, but again the numbers are so small to comment upon. But
Okay.
of course on a theory basis it looks like a promising molecule.
Okay, sir. And any questions from the audience?
Is there any difference between the polymyxin B and polymyxin E in terms of the treatment success in VAP and other non-urine tract infections?
Yeah, I'll tell you, it is very difficult to say which one is better. around 2008 or 9 when colistin was launched in India, earlier we were using polymyxin B. And I remember when I started my career in 90s, since then polymyxin B was available in India, although one or two companies were making it and it was not being marketed as it is being marketed extensively nowadays. That time very few companies were making. I think probably one or two companies were only making the polymyxin B. And very few people were like, nobody was talking about polymyxin B in any of the meetings and conference. Then in around 2009 or 10, the colistin was launched in the market. And then the hype created. And it is not the hype. We saw the resistance pattern changing very fast. And gradually earlier the data was not available from center to center. In last 20 years the people started sharing data as well. So now we realize that what is happening, and that's how this colistin picked up. But in the last 5 or 6 years or maybe 10 years, people have started noticing the toxicity of colistin, and gradually polymyxin B has replaced the polymyxin E or colistin. Although everybody knows about the drug and pro drug thing, but again this is what is happening.
And is there any loading dose or full dose?
Yeah, loading dose to me, as per my
Poly B.
poly B or colistin both, to me the loading dose should be given.
So what it should be? 15 or 10? Loading dose.
You're talking about
Poly B.
poly B. So it depends on the patient weight, what volume of distribution are you thinking of the patient. If my patient is a good built and I feel that his tachycardic, you feel that his cardiac output many times in sepsis, you feel that his cardiac output is 7, 8 liters. At that point of time, we'll have to give higher dose. No doubt about it.
Loading dose is 2.5
Per kg, yeah. So that loading dose has to be given. Loading dose concept depends on totally, because we think two aspects are happening in a sepsis, septic shock. One is the increase in the volume of distribution, and another is the augmented renal clearance because of the high cardiac output. But gradually, as we give fluid loading to these patients, gradually their cardiac output settles down, and at that point of time, maintenance dose we can adjust as per the creatinine clearance.
Do you think that based on venous clearance, it is important to change the dosing regimen of polymyxin B, since polymyxin B is
Not being done, I agree. Many centers they are not doing, but if my patient is having severe renal dysfunction, probably at that point of time we can.
that colistin would be
Colistin,
much better than polymyxin B at that time?
no.
That would, because colistin has a great result on UTI, it gets converted from chemo.
Obviously, the Eurosepsis.
Urosepsis, the polymyxin becomes the better option.
So polymyxin B has no.
That is what I'm saying. So if it doesn't happen efficacy on the UTI, doesn't get cleared by the renal pathways, then is it necessary that if based on creatinine clearance, you have to switch?
So there is one aspect of nephrotoxicity, another aspect is neurotoxicity as well.
Where you are.
No, his question, his sir,
Not MCR, one thing is something is colistin resistant. So obviously polymyxin and colistin
both are not working on the MGR1.
going to work on that.
No, his question is something different. He's saying in a patient who is having, say for example, blood-borne infection and he is having renal failure. So whether in that patient, acute renal failure, whether in that patient would you like to change the dose of polymyxin B or not? No.
Initial loading dose is the same.
No, maintenance days, even maintenance dose.
Dose adjustment is not there.
With polymyxin B it is not there. With colistin it is there.
Obviously, doctor
Not for that.
Urosepsis, it's better to give colistin rather than polymyxin B.
do you give cocktails with the different?
Look, there are, again I have told, there are two school of thoughts. One say never give alone. Another school of thought says why to waste cocktail. But if I am getting sensitivity with two drugs, probably I'll give both of them in a life-saving, in a patient who is at life-threatening situation, especially in the septic shock. So the combination remains, if I tell you the exact combination remains either tigecycline, especially in Acinetobacter earlier days, now which has gone down drastically in corporate hospitals. Now we are more dealing with E. coli or this KPCs. In that, the combination could be ceftazidime, avibactam along with colistin. That could be one option. Another option could be your old drug along with the Alores along with the colistin. So if I can enumerate, there are only, in my practice, believe me, I'm not giving as a guideline to anybody, I'm just expressing my practice. It could be wrong, it could be right. Somebody can say you are doing a wrong practice. Somebody can follow what I'm saying. We have got, to me, for MBL, we have got only 3 options right now. Zevisefta, Aztreonam, plus this thing, avibactam. If you remove avibactam, you can combine avibactam along with Aztreonam. That is one option. Then ceftriaxone, sulbactam, EDTA is another option. Third option is colistin. Off the record, I can say that we have started using Zevisefta, Aztreonam along with EDTA also. Yeah, that is the off the record, because I cannot say, and we are getting good results. It's not, the numbers are not so great that I can quote it, okay, it is having effect, but to me, I feel that we are getting fairly good results. Neurotoxicity. Look, in a critically ill patient, sometimes it becomes very difficult to judge the neurotoxicity as well, unless the patient is going home hale and hearty, because there are multiple. If my patient is admitted in ICU for a month, critical illness neuropathy will be there. Multiple factors are there, because if patient is in ICU for 1 month, one thing, patient must have received steroid, patient must be on a ventilator because of some reason, neuromuscular blocking agent must have been used, polymyxin in 1 month, he must have received the polymyxin. So pointing out fingers only at polymyxin is very difficult. Number 2, that patient who is critically ill on ventilator or in ECMO for a month, going home, he never goes home like you and me. They require very long duration of rehabilitation. If a patient is in ICU for a month for life support system, he or she requires at least 2-3 months of rehabilitation at home. So again, it becomes very difficult to point out what are the residual effects of the disease, or it is because of the toxicity of particular drug, because you have used so many drugs during that period.
So any more questions from the audience? So in that case, I would like to close the session, and I would like to thank Dr. Deepak Govil for an insightful session, and I would like to thank all the audience for keeping the session very lively